Hey, hello. Good day, everyone. So now we're now in our second week of our sessions. So last week we started with the basics. We talked about what epidemiology is, the history, and how it applies to hospital administration. Now we also discussed descriptive and analytical epidemiology. And we also discussed the different types of study designs and how it is measured. So we'll go now in deeper detail the different measurements for these next two sessions. For this session, we'll be focusing on disease frequency measures. So by the end of this session, you will be doing actual computations, but these are very basic. You don't just memorize formulas, but you should also understand what the numbers mean and what decisions they should drive. That's where epidemiology becomes an important management tool. So at the end of this session, so you'll be able to define and distinguish incidence, prevalence, attack rate, and mortality rates. These are not interchangeable terms. Each one answers a different question about disease in a population, and confusing them leads to bad decisions. Second, you'll apply the correct formulas to compute disease frequency measures from raw data. Computation is not optional. As future hospital administrators, you'll be reading health reports, surveillance data, and outbreak summaries. So math cannot escape even those working in the healthcare sector. You need to verify these numbers by yourself. Third, you have to interpret computed values in hospital administration in a public health context. A number without interpretation is useless. What does, for example, an incidence of 4 per 1,000 mean for bed planning? What does a mortality rate of 2.2% tell you about the management of critical case patients? That interpretative skill is what we're trying to build. And lastly, you'll analyze real-world study data using these measures. We'll look at actual published examples as we would go along in our session for today. So what are the disease frequency measures? So let us establish this concept. So at its core, the disease frequency measure is a way of quantifying how often a disease occurs in a population. It is the foundation of all epidemiologic analysis. Without it, we cannot compare, we can't plan, and we cannot intervene. So there are four basic types of disease frequency measures. The first one is count, which is the simplest. Simply, it's just the raw number of cases. So for example, 250 dengue cases were recorded in July. That is useful for basic situational awareness, but it has a major limitation. It doesn't it tells you nothing, no, about the size of the population. 250 cases, for example, in a city of 500 people has a different impact as compared to 250 cases in a city of 1 million people. So you have to you really have to contextualize the number of cases in relation to the number of population. The second one is ratio, which is simply comparison of two quantities that may or may not be related. So the usual would be male-female ratio. For example, there are 1.5 males for every one female diagnosed. Ratios help us compare subgroups, but again, they don't account again for population size because you're just comparing, for example, cases. The third one is proportion. Now, a proportion is a fraction where the numerator is a subset of the denominator. So, if, for example, there are 500 diabetic patients out of 2,000 individuals, that is 25%. They are useful now for describing the makeup of the population. But this time, that its limitation is that it does not account for time, which leads us to the fourth disease frequency measure, which is the rate. A rate is the event per population per unit of time. So, for example, 50 new cases per 1,000 people per year. So, this is the most powerful and most commonly used frequency measure in epidemiology. So, you have to take note that rates are the most useful frequency measures because they account for both the number of cases and the size of population at risk, which allows valid comparisons across different populations and time periods. So, a hospital in Cebu, for example, and a hospital in Metro Manila will almost always differ in raw case counts simply because of the population size. But comparing their rates puts them on equal footing. So that makes it the determining the rate very important. So what are some of these rates? The first one would be the incidence rate, which is the most fundamental measurement that we will cover. In definition, it simply states it measures the number of new cases of a disease that develop in a population at risk during a specified time period. The key word here is new. We are not counting people who already have the disease, only those who newly develop it or was newly diagnosed. So the formula for this would be new cases divided by population at risk times K, wherein the K is a multiplier, usually 1,000 or 100,000, depending now on the per population that you would like to um, standardize your rate. We use K because raw proportions like 0.004 are very hard to communicate. But it's much easier if we would, for example, say 4 cases per 1,000 people. One important technical note, when follow-up periods vary among individuals, for example, in a long cohort study, which usually takes years, and where some participants drop out early, we use person time in the denominator instead of a simple head count. Person time is the total amount of time that all individuals in the study were actually at risk. So, for example, if there are 100 people, uh, are followed for an average of 5 years, that's 500 person years of observation. It ensures we're not over or undercounting the exposure time of these patients or these individuals. So in application, for example, in the hospital setting, you'd use the incidence rates, for example, to monitor new TB cases in the wards, or track post-operative infection rates per 1,000 discharges for a particular period, for example, per quarter or every 3 months. If your post-op infection incidence rates rises every quarter, something in your sterilization or surgical protocol that may need to be reviewed or looked into. An example now of where incidence rate is being determined is the framing heart study. Again, I mentioned this in the week one, session one, it's one of the most important epidemiological studies, which started in 1948 and it's still ongoing. Um, Framingham is a city in Massachusetts. So initially, they enrolled about 5,209 adults that does not have any cardiovascular disease. And they are tracked for decades, not just years, generation after generation, to check no if who develop cases of heart disease. So framing heart study has become a gold standard for incidence studies because they started at a population wherein they don't have the disease and then they are observed over time. So the result of this one, they determined that the incidence is of 7.8 per 1,000 person years among middle-aged men. So what did that number now signify? It was through tracking incidents that researchers identified the major risk factors like smoking, hypertension, and high cholesterol. And we now use these things worldwide to screen patients, guide hospital admission criteria, and develop discharge protocols, and even develop the management for these heart diseases. The incidence data from Framingham essentially shaped modern preventive cardiology. Now, prevalence is different. So it is not interchangeable with incidence. It is defined as the proportion of a population that has the disease. So it includes new and old cases at combined at a specific point in time or during a specific period. Unlike incidents, we're not asking who got sick. We're asking who is sick right now. So there are two types of prevalence. The point prevalence, so it answers the question, how many people have the disease at this exact moment? So the formula is cases at time t divided by the number of population times k. So again, it's per 1,000 or 100,000 individuals or population. Period prevalence, meanwhile, is how many, it answers the question, how many people had the disease at any point during this time window. So it talks about a certain period, and it's not just this determine a particular point in time. So you determine it by um, dividing cases during period over the population times k. Again, depending 1,000 or 100,000. So it is an important planning tool also. For example, if you want to estimate how many diabetic patients in the outpatient clinic that they serve in a given month, you use prevalence data because there are newly diagnosed diabetic patients and diabetes is just controlled. It's not being cured. So you have existing patients that goes back to the outpatient clinic. So you can plan for specialty clinics that we deal with potential diabetic related complications. You could also increase bed capacity because there are some diabetic complications that leads to hospitalization. So, but everything from that, it starts with the prevalence. It tells you the existing disease burden and how it will affect your healthcare system or your hospital. So an example would be this one, no, the global disease prevalence, which is conducted by the International Diabetes Foundation in 2021. So their finding, they discovered that the prevalence is 10.5%. So estimated about 537 million adults, so more than half a billion individuals worldwide. In the Philippines, there's also a DOH study. So the prevalence is about 8% of the adult population. So now think about what these prevalence figures draw. It influences the national health budget. So there's sometimes the need to be restructured. Drug procurement for these medications change, and especially staffing in hospitals have to be increased. Prevalence data is what makes the case for resource allocation. So as a hospital administrator, when you go to your board of directors and say we need to expand our diabetic care unit, you're anchoring that argument by using prevalence data. So now let's look conceptually the incidence prevalence relationship. So how they are mathematically and practically linked. So the key relationship here is prevalence is similar to incidence times the average duration of disease. So there is a profound implication here. So let's look at three scenarios here. So if, for example, in the first scenario, there's a high incidence rate, but short duration. So you think of seasonal diseases such as influenza. The incidence rate is quite high, and many people got infected, no, of flu during a particular season. But uh, the natural course of the disease, the influenza, that it usually resolves between 7 to 10 days. So at any given point, relatively few people are still sick. Therefore, there is a lesser existing cases, so there is low prevalences. the cases come and go quickly. So the turnover rate of flu patients is much faster. They don't accumulate in the pool. The second scenario now is, what if there is long incidence and the disease is of a long duration in terms of its natural history? So an example that I will give would be the HIV infection or AIDS before the treatment, no, of the antiretroviral therapy has been established. So incidence rate for HIV is not really exceptionally high. But remember, the disease course was essentially a life sentence. And but the patients live for years before dying. So the cases accumulates over time, and this means there is a high prevalence. So even if there is a relatively few new cases per year, there is a growth of that pool. The last would be the ART paradox. So now, during the time now that the antiretroviral therapy has become widely available, now the incidence started to fall and there are fewer new infections. So it's decreasing. But what happened to the prevalence? It increased. The reason for that is that the medication, the antiretroviral therapy, dramatically extended the survival of those individuals with HIV infection. Um, Initially, no, those who would die in 3 to 5 years based on if it is left untreated, now the individuals can live 10, 20, and even 30 years. Magic Johnson is a prominent example. So he's been living for what? For more than 30 years, being in 35 years to almost from the day that he announced that he has a HIV infection. So the duration increased dramatically. Therefore, there is now an increase in prevalence, even if the incidence, no, of HIV infection fell. So this is the ART paradox or the antiretroviral therapy paradox. So the lesson here is that a rising prevalence does not always mean a worsening epidemic. It could mean that your treatment is working. So understanding this policy prevents the misinterpretation of data, and also that translates to your health policies as well. So from a hospital administrator standpoint, for example, so if you have an AIDS clinic in your hospital, if the antiretroviral therapy programs are succeeding, you will see more HIV patients in your clinics over time and not fewer. Therefore, you have to plan your budget and your staff accordingly because there is rising prevalence. It doesn't mean that the HIV program has become a failure, but it's more of a success because you're now prolonging the life of these individuals when previously it is thought to be a death sentence. Sorry for that. The next The next concepts would be the attack rate. So it is a specialized form of incidents and used specifically in outbreak investigations. So when there is a sudden cluster of cases, for example, food poisoning at a school cafeteria, a nosocomial outbreak in the wards, this is the tool that the epidemiologists use. So it measures the proportion of exposed persons who develop the disease. And the formula is the case among exposed over those who are exposed multiplied by 100 because it's expressed in percentage. So it's not expressed as 1,000 per 1,000 or uh, 100,000 population. Secondary attack rate now is a related measure specifically for household transmissions. So the formula for that is secondary cases divided by susceptible household contacts multiplied by 100. Again, because it is expressed in percent. So it answers once the index case brings the disease home, what proportion of susceptible family members also get infected. So, for example, in COVID-19, you can use this because uh, of the contagious nature of the disease. You can also calculate food-specific attack rates. No? So this is very useful in foodborne outbreak investigations. So you can see here an example. No? So they investigated yung mga food items and then those who were exposed as compared to those who ate the spinach salad, sorry, hamburger and the chocolate milk. And then they determined who among the cases ate these particular items. And you would see here that 80% of those who ate spinach salad develop acute gastroenteritis secondary to an E. coli strain. So, therefore, the spinach salad now is the implicated vehicle or the agent that caused the E. coli gastroenteritis. And now you can trace back the contamination, whether it's in the spinach or in the other vegetables or the other ingredients. So you can analyze where the infection comes from, and you can also do certain interventions in order to prevent now from other foodborne outbreaks to happen in other areas. So mortality rates, so it measures that quantify death rather than disease. These are critical for hospital administration also because they reflect the severity of disease burden and the quality of the clinical response. So there are three main mortality rates. The first one is crude mortality rate, which is all deaths divided by the total population times 1,000. So all causes of deaths, whether it's by accident, non-accidental, whether it's malignancy or or communicable diseases. So it is useful for broad comparisons between countries or regions. But again, this has a limitation wherein it is compounded by age structure. So let's look at the example here. So in the Philippines, the crude mortality rate is 6.5 per 1,000. It's significantly lower than Japan. No? So more than at least a half, 11.3 per 1,000. But does that indicate that Filipinos are much healthier than the Japanese? Not really. Why? Because remember, the population composition of the Japanese, there's a higher preponderance of the older people. Older people die at a higher rates, no? Regardless of the quality of the health system. The Philippines, meanwhile, yung the base niya is more of the younger population, which artificially lowers the crude rate. That's why we need age standardized rates when making direct comparisons. So that is a more advanced topic that we won't discuss with this session. The second one would be cause-specific mortality rate. So it is death from a particular cause divided by the total population times 100,000. So it is a death from one specific disease. So it is used for tracking trends in a particular condition or justifying a disease-specific hospital programs or interventions in the community. So an example, no? Again, based on the DOH data, um, the cardiovascular disease mortality rate is 264 individuals per 100,000. So that means 264 Filipinos, no, per 100,000 Filipinos die of cardiovascular disease every year. So now you can justify now investments, no, in cardiac care, cardiac facilities, the expansion of services, no, such as cardiac ICU across the country. And then the third one would be case fatality rate. So this is different from the other two. The case fatality rate is not a rate in the strict epidemiological sense. It's actually a proportion. But the term is widely used and you'll encounter it constantly. So CFR answers of those who are diagnosed with the disease, what proportion dies? So it is a measure of lethality. How deadly is the disease once you have it? It is usually used in outbreak response or ICU planning. So the formula is death from a particular disease divided by the number of individuals with that particular disease times 100. So this is expressed also in percentage. So example, yung COVID-19 during the pandemic, the peak case fatality rate is 3.8%. However, at a later time wherein the vaccination uh, program has been rolled out, the case fatality rate dropped to about 0.4%. So it tells you, that the clinical protocols, a much more clear understanding of the pathophysiology and other clinical characteristics of the COVID-19 infection help reduce the lethality even if the virus was still spreading. Then, okay, let's discuss three more specialized but also very important measures. The person or potential years of life lost. This one measures the social and economic burden of premature death. It prioritizes diseases that kill younger people. So it is used to allocate public health budget. So the formula is the sum of the standard age minus the age of death for all premature deaths. So usually you use either the life expectancy or an older age, for example, 70 or 75. So, but you have to base it again on the expected lifespan of that particular population or that group. So, for each person who dies before that age, you calculate the number of years they would have lived and sum them all up. So, why is this important? Because it shifts our focus from total deaths to premature deaths. For example, a disease that kills 200 people at age 80 contributes far less dun sa potential years of life loss thus, versus a disease that kills 50 people at age 30 because that is a premature death compared to if we've died at a much more advanced age. In higher income countries, cancer accounts for more potential years of life lost than heart disease, even though heart disease, in terms of raw numbers, causes more total deaths. Why? Because cancer kills more people under the age of 65. It cuts off now the other productive life years. So this data drives cancer research funding and why oncology departments receive disproportionate investment relatively to raw mortality numbers. So as a hospital administrator, the data tells you which diseases to prioritize for prevention programs and not just which diseases causes the most number of disease overall in terms of count. The second one would be the second one is the infant mortality rate. So it is computed death under those who are less than 1 year old divided by the number of live births multiplied by 1,000. So it is one of the most sensitive indicators of overall health system quality because it reflects the quality of maternal nutrition, prenatal care, delivery services, and neonatal case, all in just that one number. The World Health Organization has a benchmark. The IMR should be less than 10 per 1,000 live births. In our setting, our current IMR is 22.3 per 1,000 live births, so double than the standard that the World Health Organization gave. So compared to Japan, the IMR is just 1.7. So there is a very significant gap that tells you that in our country there are still significant deficiencies in neonatal facilities and maternal care, particularly in the rural and the underserved areas. For those of you who may administer provincial or regional hospitals, for example, this data is directly relevant to what services you need to prioritize. Because infant mortality rate in the DOH data it can also be broken down to regions and even by provinces or major cities. The third one here would be the neonatal mortality rate. So the infant is less than 1 year old, but a neonate is those who are during the first month of life. So the formula is the deaths within 28 days over the number of live deaths times 1,000. So this is a very vulnerable window. It reflects birth facility quality, the presence of skilled birth attendants, and the neonatal intensive care unit capacity. So in our country, approximately 70% of all infant deaths occur in the neonatal period. So this now justifies targeted investment in the building up of neonatal intensive care units, not just general pediatric wards, but specifically neonatal intensive care. So now let's look at an example here, a scenario no, of a dengue outbreak in Manila. So a Manila hospital serves a community of 45,000 people. So on the 1st of July, there are 360 known dengue cases. During July 180 new dengue cases developed. And by the end of the month, 12 deaths from dengue were recorded. The hospital has 500 beds and 85 patients are currently admitted for dengue. So now, we calculate the four answers. So the first one, yung point prevalence. So on July 1, so we're talking about July 1. So point prevalence is again the cases at that time, known cases, divided by the population times K. So in this case, it's 1,000. So plugging it in, 360 divided by 45,000 multiplied by 1,000. So that gives you 8. 8 persons with dengue per 1,000 population. So on July 1, 8 out of every 1,000 community members were already living with dengue. So for a hospital administrator, this tells you that the pre-existing burden entering the month July. The cases already in the system before any new ones arrive. So now for the incidence rate. This time, the formula is different because you're looking at the new cases. So now, critical step here is you're defining the population at risk, which is what is the denominator in this case? Is it still the total population? The problem here is that there are already 360 known dengue cases, an ongoing infection. So therefore, they are technically not at risk for getting dengue because they already have it. So we should subtract those known cases from the total population. So that's why it's 44,640. So 180 divided by 44,640 multiplied by 1,000 and the answer is 4.03. So during July, 4.03 new dengue cases were developed per 1,000 at-risk individuals. So this is the active transmission pressure in the community during that month. If the incidence rate is increasing for every month, it signals a worsening outbreak. How about case fatality rate? So we mentioned here that there are 12 mortalities from dengue. So we would define now yung total cases. Now, total cases would mean the old cases and the new cases. So you add 360 to 180, so that's 540. So 12 deaths divided by 540 because those are the number of dengue cases multiplied by 100. So the case fatality rate is 2.2%. So that means 2.2% of dengue cases resulted in death. The average case fatality rate for dengue is 0.5% only. So you can see here that the CFR, the case fatality rate of the hospital, is 4 times the national average, and this could raise a serious red flag. It warrants immediate review, for example, of ICU protocols, fluid management practices, and triage procedures. So, are the cases being caught early enough? Are the management of this patient is being properly administered? So, those things need to be investigated by using case fatality rate. So this is the kind of insight that makes it essential for hospital management. And it's not just mere computation of numbers. The fourth one is yung the bed occupancy indicator. So this is now we're computing for the proportion of hospital beds occupied by dengue patients. So the formula is bed occupancy equals dengue admissions divided by total beds times 100. So, although hindi nakalagay dun sa senaryo, nakalagay pala. 85% patients are currently admitted for dengue. So, and then your hospital is a 500 bed capacity. So, simply divide 85 by 500 and you get 17%. So that means dengue patients are occupying 17% of your hospital beds. So you would think that would be manageable. But remember, dengue is one of the many conditions the hospital treats. So there are too many diseases, and then we haven't even accounted for the those who gave birth, those who are operated. So if you would look at it, it is um, occupying a relatively high number of hospital beds. The proportion is relatively high. So one of the plans that you can do is you consider expanding the isolation ward capacity for in the hospital. So you have to make real-time decisions about resource allocation, against staffing, and even evacuation or referral planning. So even referring it to other hospitals can also be a solution. So that you would avoid full occupancy of of those beds, and that would cater to the incoming cases of various diseases. So as a homework, and this will be part of your Saturday activity, so there is this practice problems that you will compute these different rates. So there are three scenarios that are given. So please answer them and submit it on a document file through my email address. So you can pause the video and you compute the what is asked in every scenario. So finally, so let's go to the summary of our sessions. So one, incidence measures new cases, and it is used to study causation, risk factors, and outbreak dynamics. Prevalence, meanwhile, measures all existing cases. So the old cases that still has the disease and the newly diagnosed individuals. So you use this to plan healthcare demand and resource allocation. Third is attack rate is a special cumulative incidence rate for outbreak investigations. So, for example, you compare food-specific or exposure-specific attack rates. It helps you identify the source of that particular surge of the disease. It's how we find no the contaminated spinach in our example. Fourth, the mortality rates, whether it's the crude or the case fatality rate, it quantifies the severity and impact of diseases. For example, case fatality rate fluctuations signal ICU protocol effectiveness. So you have to monitor it closely. Finally, the potential years life loss, the infant mortality rate, and the neonatal mortality rate, it highlights premature death and health system quality. They directly inform hospital infrastructure investment priorities, such as neonatal ICU expansion, maternal care programs, and oncology services. So with that, thank you for listening, and I will entertain questions in our session later on.